Hello everyone, I'm Dr. Kruan, and in this talk I will focus on Efferent Neuro-Ophthalmology. This involves the pupils, the ocular motility, eyelids, as well as nystagmus. So let's go over the pupillary light reflex. So light enters the eye and then reaches the visual system via the optic nerves. The optic nerves are formed by axons from the retinal ganglion cells. One then has splitting of information here into the optic tracts back here, and then they leave prior to the lateral geniculate nucleus to reach the dorsal midbrain, where one has a pretectile nucleus or the PTN. Then there are decussations, so that both of the third nuclei are innervated. And fibers then reach the third nerve, and then eventually the ciliary ganglion, and then back out to the pupil. And as a result, if light enters one eye or any one of the eyes, because of this decussation that happens twice here at the chiasm as well as the level at the pretectile nuclei, will result in pupillary constriction in both eyes. Then another way to have pupillary constriction, and that is when you look at a targeted near, and we think there's a cortical command center down here in the midbrain, then out to the third nerve telling the pupil to constrict. Here's just a depiction of light that also does the same thing, but again we can think there's another way to cause pupillary constriction, the near reflex, which consists of three things: lens accommodation, pupillary constriction, and convergence in the eyes. So let's review the oculosympathetics. So the oculosympathetic system, of course, dilates the pupil, and there's a 3-neuron system. The first order neuron starts in the hypothalamus, then descends down to the brainstem and into the spine. The second order neuron travels through the brachial plexus over the lung apex, and then the third order neuron starts to disappear over the cervical ganglia and then goes into the carotid plexus. And here's a diagram again showing the first order neurons that starts here back in the hypothalamus, descends through the midbrain in the lateral part of the pons and medulla, and eventually terminates at the C8T up until from C8 till T2 nerve roots, which then forms the second order neurons here at the celospinal budge, and then as second order neurons runs over the lung apex underneath the clavicle, ascends into the neck up until the angle of the mandible, where it synapses here at the superior cervical ganglion, and then as third order neurons enters the cavernous sinus and joins the ophthalmic branch, that V1 branch of the trigeminal nerve, and exit via the superior orbital fissure to innervate the pupillary dilator. So the top pupillary abnormalities that will be covered in this presentation include an afferent pupillary defect, anisocoria, pupillary light near dissociation, and a pupillary examination in a patient with coma. So the afferent pupillary defect reflects damage to the optic nerve and can also be seen in bad retinal diseases. It's not seen with media opacities, and that is cataracts, and there's also no anisocoria. So this is an example of the swinging flashlight test demonstrating an afferent pupillary defect. So in this individual who has no pathology of either eye, both pupils are in mid position at rest. Light is shined into the right eye and causes pupillary constriction on both sides. Then light is shined into the left eye, and again there's pupillary constriction on both sides, equal to the amount of light. In this example here, this individual here has a left optic neuropathy. Light is shined into the right eye. This causes bilateral pupillary constriction. When light is moved to the left eye, the pupils do not constrict as much, and it actually appears when the light enters the left eye that both pupils are dilating compared to when it was shown into the right eye. And this is referred to as the afferent pupillary defect, this apparent dilatation of the one pupil. But it's important to remember that it's not a true dilation that happens. It's an apparent dilation because it was still constricting in this affected eye, but just less to what it was in a normal position. So it's still constricting compared to the normal position that the patient had, but it's just less compared to the initial normal eye that the light was shown into. And here's a depiction of a left afferent pupillary defect and a patient with optic neuritis. Light is shown into the right eye, and you can see both pupils constrict. When light is shown into the left eye, it looks like that both pupils are dilating, but they're still constricting, but just less compared to what it was when the light was shown into the normal eye. You can have an afferent pupillary defect in an optic tract lesion, and the afferent pupillary defect is on the side of the greater visual field glass. And typically, the afferent pupillary defect, therefore, will be on the side opposite of the optic tract lesion. That is the side with a bigger temporal field visual loss. So moving on to Anisocoria, which means unequal pupils. You can have physiological Anisocoria, and this is typically the same in dark and in light. Anisocoria can be caused by the pathological small pupil, and this is seen when the anisocoria is greater in dark. And then anisocoria can be caused by an abnormally large pupil, and this is seen when the anisocoria is greater in light. And again, if an optic nerve or retinal disease, this does not cause anisocoria. So this is the case of a physiological anisocoria. So the difference between the pupillary sizes is the same when it's in light and in dark. So you can test for a Horner syndrome pharmacologically. The most famous test is the cocaine test, and cocaine blocks the uptake of norepinephrine, so that in a normal situation, if there's intact first, second, and third order neurons, and there's a release of norepinephrine by the third order neuron, cocaine blocks it and the pupil will dilate. However, in an instance where there's any lesion in the first, second, or third order neuron, there's not as much norepinephrine around, so there's not as much pupillary dilatation. And when the pupillary response to norepinephrine is not as good as in the other eye, that's the eye with a Horner syndrome. And this is an example of a positive cocaine test. Here the individual with a smaller pupil on the right, and after the cocaine has been given, in both eyes you can see that the left dilates, but the right does not. And this does not localize the Horners, it just tells you whether the Horners is present or not. Now cocaine is becoming harder and harder to get for such pharmacological testing, and this is where aproclonidine is now becoming more popular. And this is based upon denervation hypersensitivity. And what will happen in this instance is where there's a Horners on the right and the normal pupil on the left, is that aproclonidine will lead to pupillary dilatation and eyelid elevation on the same side of the Horners. And this is based on the concept of degeneration hypersensitivity. So one can localize a Horner clinically. So what we're looking for here is a lesion in the first order neurons. For instance, that might occur with a brainstem stroke or spinal cord lesion, or it might even occur with a second order neuron due to an apical lung tumor, or a third order neuron due to carotid dissection, for instance. And in this case, because this is a third order neuron, the sweating fibers have already left the sympathetic system in the lower half of the face. So sweating should then subsequently be preserved if it's a third order Horner syndrome. So here again, we're trying to localize that first order, second order, and third order Horner syndrome. So with first order Horner syndrome or central Horners, patients typically will have a hemianhidrosis. In other words, one side of the body will not have any sweating function. In a second order or preganglionic Horner syndrome, the person will only have hemianhidrosis of the face. So the rest of the body will be spared. And then in a third order Horner syndrome or postganglionic, after the cervical ganglion, sweating will be completely preserved and still be intact. So even in the body as well as in the face. So here's an example of a first order Horner syndrome. And this is an unfortunate individual who had a fracture up here in the high cervical cord or vertebrae. And here you can see that the patient's got ptosis as well as mycosis. And they are sweating on this side of the face, but not on this side. And this is most likely because this patient had a Horner syndrome due to this cervical cord injury. So if you examine this patient, you will pick up that there's also anhidrosis on the same side underneath the armpits or in the axilla, as well as in the palms and soles of the feet. Here's an example of a second order Horner syndrome due to a Pancoast tumor. In this axial image here, there's the apical lung tumor sitting here. And this patient here has ptosis as well as mycosis due to this Pancoast tumor in the lungs. So the classical third order Horner's is due to a carotid dissection. And this patient here presents with sudden onset of eye pain and ptosis as well as mycosis. And you can see here on this axial imaging of the MRI, the classical crescent sign, and this is due to a hemorrhage that's occurred inside the media of that blood vessel. And here's the classical string sign that we can see with an angiography pictures. And this cartoon here depicts on what's happening to the blood vessel. There's dissection, hemorrhage, causing the lumen to decrease in size. And now we can localize pharmacologically. Hydroxyamphetamine enhances the release of norepinephrine at this third order end plate. And if the third order neuron is intact, the pupil will dilate. If the third order neuron is not intact, the pupil will not dilate. So hydroxyamphetamine is used to decide whether this patient has a third order neuron or not. So what about Anisocoria that's worse in light? Well, here the large pupil is the abnormal one. We're thinking about a pupil that doesn't react. So we're thinking about a pupil involving the third nerve. So it can be due to a third nerve palsy, a tonic pupil, pharmacological dilatation, or even trauma to the iris. We'll get back to this. But the classical large pupil that doesn't react, so that's something worrying for some, where you have to think about a PCOM aneurysm causing compression on that third nerve, causing that third nerve palsy and dilated pupil. So the tonic pupil is one cause of a non-reactive pupil, and the pupil does not react to light, but it does react to a near response. So when the person is asked to converge their eyes, it will react to convergence. So what is the pathophysiology of this light near dissociation? Well, there's a 30:1 ratio of fibers from the ciliary ganglion going to the pupillary constrictor in the near versus light reaction. So if there's damage to the ciliary ganglion, there's still many more fibers for the near light reflex. You can also have pupillary light near dissociation with aberrant regeneration of the accommodative fibers. So there are 5 important causes of a light near dissociation. We've talked about the tonic pupil. Again, we also have aberrant regeneration of the third nerve. But there are 3 more to consider, and they are deafferented pupils. If you have a section of the optic nerve here, and then the pupil will not react to light shown into both eyes, but it will react when the patient is asked to look at a near stimulus. And then you can have midbrain lesions in the so-called Parinord syndrome, where one has a mid-position non-reactive pupils to light, but they can react to near. And then there's the classic syphilic Argyll Robertson pupils. These pupils are small and non-reactive to light, but again react to near convergence. So here's an example of dorsal midbrain syndrome with mid-position pupils, which are unreactive to light but will react to near. The patient also has upgaze paresis, convergent retraction nystagmus, and eyelid retraction. This is due to compression of the ganglion cell axons in those involving the pretectile nuclei. Here's an example of a patient with a large pineal region tumor with pupillary light near dissociation. The way to remember Argyll Robertson pupil is actually in the name. So by a mnemonic, you can think of Argyll Robertson. So Argyll would be accommodation is retained, but the double L would stand for light reflexes lost. So accommodation retained, light lost. You should be familiar with pupils in coma, and in metabolic coma, the pupils tend to be small but reactive. In large midbrain lesions, they tend to be mid-position and fixed. The classical Pontine coma examination with reveal pinpointed pupils, and then uncal herniation, you'll have one or both pupils which are dilated and fixed. And this is, of course, taken from the classical scheme of the herniation syndromes. So when you're evaluating ocular motility deficits, you should think of key questions. Here the patient should be asked if the double vision is binocular or monocular, horizontal or vertical, worse with distance or with near, and if there's any particular direction of gaze where the motility is worse. So these are the pathways for localization. You have to know what type of muscles do and what innervates each muscle. Here, of course, you know that the eye muscles are innervated by the 3rd, 4th, and 6th nerves. They are both supra and internuclear pathways, and you want to ask whether the pupils are involved or spared. So the superior rectus is innervated by the 3rd nerve and elevates the eye, best seen in abduction. The inferior rectus muscle is innervated by the 3rd nerve and depresses the eye, best seen in abduction. The superior oblique muscle is innervated by the 4th nerve and depresses the eye, best seen in adduction. The inferior oblique is innervated by the 3rd nerve and elevates the eye, best seen in adduction. The middle rectus muscle is innervated by the 3rd nerve and adducts the eye as well, and then the lateral rectus is innervated by the 6th nerve and abducts the eye. The levitator palpebral muscle is innervated by the 3rd nerve and elevates the eyelid. So it's important to note that the superior rectus, inferior oblique, medial rectus, and levitator palpebral muscles are innervated by the 3rd nerve. The 4th nerve innervates the superior oblique, and the 6th nerve innervates only the lateral rectus muscle. So here's an anatomical drawing of the muscles as they come from the annulus of Zinn. Here you have the oblique muscles that's inserting into the eye, and here you have the superior rectus as well as the inferior rectus muscle. And again here at the back of the orbit you can see the annulus of Zinn, and this is obviously the front of the eye. So this is another way to think about which eye muscle moves the eye and which eye muscles are innervated by which nerves. The only nerve which elevates the eye is the 3rd nerve, because the 3rd nerve innervates the superior rectus as well as the inferior oblique muscles, as in this example of the right eye. And the muscle which moves the eye down in abduction is the inferior rectus, innervated by the 3rd as well. And here you have the medial rectus, which adducts the eye, and that is also innervated by the 3rd. Now the 6th nerve, as we said earlier, is the nerve which innervates the lateral rectus muscle, which abducts the eye, and the superior oblique muscle intorts the eye, which moves the eye down and in, best seen in adduction, and that is innervated by the 4th nerve. So now we should start to localize, and you should think in terms of whether the lesion is sitting in the brainstem, nucleus, or is it in the fascicle. Remember, that's the part of the nerve that just left the nucleus, but it's still within the brainstem. Is the lesion in the subarachnoidal space, or in the cavernous sinus, or even at the orbital apex? So these are the areas where the nerves that governs extraocular movements can localize to. So let's talk about 3rd nerve palsies. These produce binocular, vertical, mixed, and horizontal diplopia. The double vision may be masked by ptosis. That happens if the eye is completely down with ptosis. So you will only be able to look out of one of the eyes, and therefore you will mask the double vision. You should start to worry about compressive 3rd nerve palsies when there's associated headache and pain. So if the lesion is in the nerve or the nerve fascicle, the eye will also be down and out. There will be difficulty with abduction and supraduction, as well as infraduction of the eyes. There will also be pupillary dilatation and ptosis. Occasionally you can have just a superior division 3rd nerve palsy, and this would involve the levitator as well as the superior rectus muscles. Other times you might have just an inferior division palsy, and this involves the pupil, inferior medial rectus, as well as the inferior oblique. There is a classical division of the superior and inferior divisions that occurs at the orbital apex just after the cavernous sinus. So here's an example of a pupillary involving right 3rd nerve palsy. Here the eye is down and out, and the eyelid is ptotic. The eye doesn't elevate properly, it doesn't adduct properly, and it doesn't depress properly as well. So the ptosis is caused by a problem of the levitator palpebris superioris muscle. This problem here is caused by superior rectus as well as inferior oblique palsy, and this is a problem due to medial rectus palsy, and this is a problem due to the inferior rectus muscle that is non-functioning. Here's an example of a fascicular 3rd, the 3rd nerve that starts here in the back of the midbrain, exits ventrally. And here we can see this on this gradient Echo MRI. This patient has a third nerve palsy, and the lesion is sitting here in the peduncle of the midbrain. So a nuclear third nerve palsy is unusual, but it is characterized by bilateral ptosis, bilateral superior rectus weakness, because you have an associated unilateral third nerve sign as well. It's a rare condition, and I have mentioned it in the brainstem lecture as well. Fascicular third nerve syndromes can be seen when there are various lesions in the midbrain, typically caused by ischemic strokes in the midbrain. The key here is that the third nerve palsy on one side, and the patient typically have neurological problems on the other side. If you remember that 4-4-4 rule that I mentioned. So remember, it was the 4-4-4 rule, going from dorsal to ventral, lateral to medial. So the classic, of course, is Weber syndrome. And this is due to a lesion in the cerebral peduncles causing an ipsilateral third nerve palsy and a contralateral hemiparesis, if you think about that ventromedial midbrain syndrome. The next most popular one is cloud syndrome, with an ipsilateral third nerve and contralateral ataxia. And that's because of the cerebellar fibers involved in that red nucleus. So remember, if you recall, that would be the dorsal medial midbrain syndrome. And then we have Benedict syndrome, which is due to a lesion of the third nerve as well as the substantia nigra / cerebral peduncle, causing a contralateral movement disorder as well as tremor. So I showed you this photograph earlier. This was a lady that presented with a PCOM aneurysm with ptosis and an ophthalmoplegia on the right. Here's an aneurysm sitting here, and it's easy to see in this cartoon here how easy it is for the third nerve that it can be compressed by an aneurysm. You can have an aberrant regeneration of the third nerve after trauma or compression. And what happens here is that fibers that were supposed to go to one particular muscle, the third, now go to another one after injury. So the classical combination of lid gaze dyskinesias occurs when there's retraction of the eyelid in down gaze or an adduction. It is one of the classical syndromes of an aberrant regeneration. Another one is where pupil gaze dyskinesias occur, where there's constriction of the pupil in down gaze or an adduction. Here's an example of a patient with eyelid retraction on down gaze. So this pupil has actually been pharmacologically dilated. So third nerve palsy can occur in children as well, and one cause you should be aware of is called ophthalmoplegic migraine. This girl here presented with acute ptosis and headache, and she had a family history of migraine. It might be considered today that it's not really a migraine condition, but it's actually an inflammation of the third, or forms maybe part of Toulouse-Hunt syndrome or even orbital pseudotumor. So a fourth nerve palsy is present with binocular, vertical and oblique double vision. This increases on contralateral gaze, and you'll get a tilt on one image, in particular when you tilt the head towards the side of the fourth nerve palsy. You can also have a lesion of the nucleus or fascicle, because of the fourth nerve nucleus is contralateral to the nerve itself. This happens because the nerve leaves dorsally and it crosses the back of the midbrain before heading into the cavernous sinus. One has contralateral superior oblique palsy if this lesion occurs in the brainstem. If the lesion is in the nerve, you would have an ipsilateral hypertropia, which is worse than contralateral gaze, and there's head tilt away from the fourth nerve palsy. Here's an example where there's a patient with a left fourth nerve palsy. The left eye is higher than the right because the eye cannot be brought down by the paretic superior oblique muscle. The patient has less of a hypertropia in head tilt away from the fourth nerve, and worsening of the hypertropia when the head tilt towards the fourth nerve palsy. Now in nuclear or fascicular fourths, again, as I said, there's contralateral superior oblique weakness. There can also be ipsilateral Horner syndrome because of the sympathetics that run very close to the fourth nerve nucleus, and lesions in this area can be caused by hemorrhages, demyelination, as well as trauma. So let's move on to a sixth nerve palsy. These cause binocular horizontal double vision, and the esotropia that is found is increased in ipsilateral gaze, and it worsens at a distance. Now if there's a nuclear sixth nerve lesion, and the same thing can be seen with the paramedian pontine reticular formation lesions. If you remember what I mentioned in the brainstem lectures, you actually get this ipsilateral horizontal gaze palsy, and not just the sixth nerve palsy. And we'll talk about the anatomy of that again in a second. The ocular cephalics are intact in a patient if the PPRF lesion is the cause of the gaze paresis, because the vestibular fibers go right past the PPRF and then they go directly to the sixth nerve. You can also have a nerve or fascicle lesion. In this case, there's just an ipsilateral abduction deficit and then esotropia, which is worse on gaze towards the lesion. So this is actually the left frontal or cortical fields, which will tell the person to look to the right. The fibers will descend into the brainstem, and then they will cross and reach the opposite OPN, or omnipath neurons, which will then tell the PPRF to excite the sixth nerve, which then causes the ipsilateral lateral rectus muscle to contract to the right. But if you can recall correctly from the brainstem anatomy lecture, there are fibers coming in from this sixth nerve nucleus, which actually cross via the medial longitudinal fasciculus, or MLF, to tell the medial rectus, or the medial rectus subnucleus on the other side, in the third nerve nucleus, to move the medial rectus of the other eye at the same time when the lateral rectus is moving. So this will cause the left eye to move to the right as well. Also, this is coordinated effort of the sixth nerve, MLF, PPRF, and the third nerve, which allows both eyes to move at equal times to the right. And these eye movements that move equally to the right are referred to as conjugated eye movements. So they conjugately move to the right or to the left when the opposite side is activated. So this is a schematic of pursuit eye movements. I think the details are a little bit redundant, but it's suffice to say that a lesion on the right frontal eye fields or supplementary eye fields, even V5, may actually lead to an ipsilateral gaze problem and not a contralateral gaze problem. And that's for pursuit eye movements. So here's an individual with a right sixth nerve palsy, and you can see that there's an abduction deficit happening here. There's bilateral papillary edema. The patient has an inflammatory tissue on the mastoid and has secondary venous sinus thrombosis due to a mastoiditis, elevated intracranial pressure, and as a result has a sixth nerve palsy based upon this basis. Here's an example of a sixth nerve due to an intrinsic pontine abnormality affecting the fascicle. This patient has a bony problem and has a subsequent pontine glioma. So one can also involve the oculosympathetics and have an ipsilateral Horner syndrome. Again, we discussed that if the paramedian pontine reticular formation is affected, one can have an ipsilateral horizontal gaze palsy. If you have just a lesion of the medial longitudinal fasciculus, you will develop an ipsilateral intranuclear ophthalmoplegia with weakness of the ipsilateral medial rectus. If the sixth nerve is involved with an ipsilateral pyramidal tract, you'll get a contralateral hemiparesis. And if the seventh nerve fascicle is involved, you can also have a peripheral seventh in addition to the sixth nerve palsy. And if you remember, that constitutes part of the syndrome called Miller-Gabler syndrome, and that was also part of the brainstem lecture that I mentioned. So let's look at the anatomy here. Here's that fourth ventricle, and here's the ventral pons. Here is that sixth nerve nucleus issuing its fibers, and which becomes the sixth nerve. Notice here that the seventh nerve swoops around the sixth nerve nucleus and exits off to the side here. If you have a lesion here in this area marked in red, you will have what is called the facial collicular syndrome, which I've mentioned already, where there is a gaze palsy to the left, and in addition, you will have a fascicular seventh nerve palsy on that same side as well. So now I'm going to look at an entity that's called 1.5 syndrome, and you should understand where this lesion is in 1.5 syndrome. So the 1 in 1.5 syndrome is the gaze palsy to a left, as we can see here, and the half it represents the intranuclear ophthalmoplegia with weakness of the left medial rectus here on the right eye. So what causes this particular syndrome? Well, the left gaze paresis can be caused by a lesion here in either the sixth nerve or on part of the PPRF. The intranuclear ophthalmoplegia on the left is caused by injury at the same time to these crossing fibers coming from the opposite sixth nerve, which is supposed to have gone to the MLF, but are injured here, and that's why the left medial rectus does not contract. Therefore, the only eye movements that you will see is abduction of the eye opposite of the lesion. So looking at the causes of 1.5 syndrome, the most common causes in individuals less than 50 years of age would be demyelinating conditions as seen in multiple sclerosis. In individuals above the age of 50 years, stroke would be one of the common causes of 1.5 syndrome. Common etiologies of a third, fourth, and sixth nerve palsy include nerve ischemia, the so-called vasculopathic third, fourth, or sixth nerve palsies. These tend to occur better on their own. One can also have traumatic nerve palsies, especially the fourth nerve palsies. Unfortunately, neoplasms can also cause a third, fourth, and sixth nerve palsy. And one can have inflammation and demyelination, causing palsies of these nerves as well. Now, isolated palsies can also be caused by brainstem infarction and hemorrhages, as well as brainstem injury. High-grade vessel stenosis can cause ischemia to the nerves, and rarely one can also have an isolated oculomotor palsy seen in pituitary apoplexy. Now let's talk about cavernous sinus syndrome. The third, fourth, and sixth nerve come together here in the cavernous sinus, and this triangular area here is just lateral to the pituitary gland. And notice that the cavernous sinus wall contains the third, the fourth, as well as the V1 and V2 branch of the fifth nerve. But the sixth nerve is situated here and it's free floating. Here you have the carotid artery and it's wrapped in the sympathetic plexus. So with a complete cavernous sinus syndrome, you would have a combination of the third, fourth, and sixth nerve palsy, as well as sensory loss over V1 and V2 distribution. Remember that V3 of the trigeminal nerve is not part of the cavernous sinus. There can also be associated third order Horner syndrome. If the lesion is larger and goes outside of the cavernous sinus, you can have an associated optic neuropathy as well as chiasmal involvement. And if it goes into the orbit, you will definitely have orbital signs as well as possible orbital pain. So here's a large view of the previous diagram, and you can see here that the sixth nerve lies within the sinus and not along the wall. Now, as these nerves approach the orbit, they enter the orbit into a hole in the sphenoid called the superior orbital fissure. And it's important to know which nerves goes through the superior orbital fissure. And that would be the third, the fourth, the sixth nerve, as well as V1. Note that V2 of the trigeminal nerve does not go through the superior orbital fissure. So if it's missing V2, which is the only clinical feature which distinguishes a cavernous sinus syndrome from a superior orbital fissure syndrome. So in the orbital apex, you just have a third, fourth, and sixth nerve, as well as V1. But now it also includes an optic neuropathy. Note that an optic neuropathy was not part of the superior orbital fissure syndrome that I just discussed. And so when you have a lesion in the orbital apex, you will have a third, fourth, as well as a sixth nerve palsy and V1 sensory loss with an associated optic neuropathy. And because this is typically of an orbital process, you must be alerted to this with the possibility of having proptosis and orbital signs such as pain and tenderness. So here would be the place where you would have an orbital apex syndrome, again, where all the nerves come together with the optic nerve. Now it's important that you should always have a differential diagnosis, which causes an acute lack of eye movements in all directions, and this would be referred to as an acute ophthalmoparesis. This would include pituitary apoplexy, various orbital diseases, giant cell arteritis, due to ischemia to the nerves as well as the muscles. You'll have carotid dissection, again due to ischemia of the nerves, myasthenia gravis, Wernicke's encephalopathy, especially if there's bilateral sexes and a history of malnutrition or alcohol intoxication, as well as medication toxicity, such as due to phenytoin and others. So orbital diseases are usually evident when there's orbital signs again, such as proptosis. Here you have a chemosis of the patient's conjunctiva, as well as periorbital swelling, which you consider to include cellulitis, mucormycosis, as well as aspergillus. conditions which can also cause orbital disease include thyroid eye disease. And here's a CT scan where you have multiple thick eye muscles. This would also cause an ophthalmoparesis. Orbital pseudotumor is an inflammatory condition which is highlighted by double vision and pain, and the carotid cavernous dural fistula can also cause unilateral ophthalmoplegia, unilateral or bilateral ophthalmoplegia and pain, and patients may also have a history of a bruit on auscultation of the eye. So it's always important to consider myasthenia gravis in a patient with a pattern of ophthalmoparesis that may or may not fit in with a particular cranial nerve palsy. So this patient here presented with an abduction deficit of the right eye and was thought to have had a 6th nerve palsy. Months later, the patient showed up with bilateral ptosis. And here you have that so-called curtain sign, where one eyelid is elevated and the other subsequently falls due to the consequence of Hering's law of reciprocal innervation of both eyelids. Other gaze disorders include the dorsal midbrain syndrome, the so-called Parinord syndrome, where you cannot look up or down. You have a vertical gaze paresis. You can also have skew deviation, where there's vertical misalignment of the eyes due to injury of the vestibular nerve or nuclei or pathways. Then you can also have an internuclear ophthalmoparesis, as we discussed in great detail. And then parietal lesions, as I discussed, can also cause an ipsilateral pursuit abnormality. And then there's also the frontal eye fields, which can cause a saccadic eye abnormality away from the site of the lesion. So here in this diagram, I think the important thing to get out of this is that here is the location for the frontal eye fields for saccades, the parietal eye fields for pursuit. And here you have the dorsal midbrain for vertical gaze. We've already discussed the connections from the 6th nerve as well as the PPRF for horizontal gaze. But now, right here, you have the depiction of the vertical gaze centers, which includes the MLF, the RIMLF, the rostral interstitial medial longitudinal fasciculus, as well as the interstitial nucleus of Cajal, and then subsequently the posterior commissural fibers, which will tell the 3rd and the 4th nucleus to move the eye up and down. Skew deviation is caused when there's interruption again of the vestibular pathways which subserve the vertical gaze. So you can also get a vertical misalignment from a skew deviation where the one eye will be higher than the other, and you can localize this to the hypertropia based upon the level of injury. So in a midbrain lesion, the lesion is typically ipsilateral to the hypertropia, and it will also be associated with lid retraction in that eye. And the lesion is typically contralateral to the hypertropia when it's in the medulla, and is associated with a Horner syndrome in this case. We will call this the high-high, low-low mnemonic. So let's finish with nystagmus and nystagmoid eye movements. So nystagmus is a rhythmic oscillation of the eyes. It can have a central or peripheral localization pattern. Pendular nystagmus has no fast phase, whereas jerk nystagmus has a fast phase and then it's followed by a slow phase. So the fast phase defines where the direction of the nystagmus is when we name the nystagmus. So there are two types of nystagmus, and it's probably best to think of all types of nystagmus within these two categories. You get pendular nystagmus and jerk nystagmus. Common nystagmus types which have pendular waveform include oculopalatal myoclonus, oculomasticatory myoarrhythmia, which is seen in Whipple's disease, seesaw nystagmus, as well as spasms mutans, which is the combination of an asymmetrical shimmering nystagmus, head tilt and head nod seen in children. And then there's also congenital nystagmus, which is mixed pendular and jerk. And then there's nystagmus can also occur with monocular vision loss, which can cause a monocular pendular form of nystagmus. Jerk nystagmus is seen in vestibular diseases, either peripheral or central. Gaze-evoked nystagmus can occur specifically with Brandt's nystagmus, which is a lesion in the CP angle, and then you can have periodic alternating nystagmus, which starts in right gaze and then after 90 seconds or so switches to the left gaze. Then you also have upbeat nystagmus as well as downbeat nystagmus, which are jerk waveforms. And then also you can have convergent retraction nystagmus as well as drug-induced nystagmus. And these are typically then gaze-evoked in nature. So the nystagmus, the fast phase, alternates between the two sides. If the person looks to the right, the nystagmus will be to the right. If the person looks to the left, the nystagmus will be to the left. Now for localizing nystagmus. So downbeat or periodic alternating nystagmus localizes to the cervical medullary junction. Upbeat nystagmus is non-localizing and can be seen anywhere in the posterior fossa, the cerebellum, the pontomesencephalic or pontomedullary areas. Convergent retraction nystagmus localizes to the dorsal midbrain, and then Brunt's nystagmus, as I said earlier, localizes to the CPA angle. And then we have seesaw nystagmus, where the one eye goes up and the other one goes down in an alternating fashion, which localizes to the paracellular region and rarely to the midbrain. So looking at the difference of jerk nystagmus, it can either take the form of physiological or pathological variants. So physiological nystagmus are higher frequency, low amplitude forms of nystagmus as opposed to the pathological variants. It's typically more symmetrical, and it resolves upon 3/4 of gaze. So if you go to the extremities of gaze, it typically elicits physiological nystagmus. By bringing in your finger by 10 degrees, it typically resolves when you've got a physiological nystagmus, as opposed to pathological jerk nystagmus will still be persistent even when it's at 3/4 of gaze. And then these are some variants that you will see with jerk nystagmus that's always pathological, as opposed to physiological nystagmus either typically has a horizontal and unidirectional component. And that will conclude the talk for Efferent Neuro-Ophthalmology, and I hope you learned a lot during this talk and it was informative for you.